Welcome to another episode of the Federal Newswire's Business of America podcast with your host, Jerry Rogers.
Welcome back to another episode of the Business of America, where we talk to the doers, the makers, the thinkers, the persuaders, the advocates, the experts. And today is perfectly in line with what we've been doing. That is talking to the men and women in the arena. And with us today, I am pleased to say we have Martha Nolan, who's a senior policy advisor at HealthyWomen. HealthyWomen have been hosting here in D.C. Capital conversations about myriad health issues. And recently, we addressed the PBM issue, pharmacy benefit managers. We're going to talk about that today, drug prices and this sort of thing, impact on patients. But also joining us, and he was on a panel for HealthyWomen with me not long ago, is Mike Stancil. He's the vice president for strategic alliances at AffirmedRx. And Mike works for, represent a PBM. So we're going to get a very interesting, unusual, maybe even contrarian view of the PBM debate. But Mike, let me start with Martha. And Martha, welcome. Thank you so much for being with us. So out-of-pocket costs are rising. For drugs, women make up, I think, 78% of women. 78% of women take prescription medicines compared to 58% of men. So 71% versus 58%. Talk about the impact of health costs, drug prices, access to medicine from a healthy women's perspective.
Well, I mean, the reality, well, first let me say thank you. I appreciate being on with you today and discussing this incredibly important topic that impacts literally all Americans. I've always felt strongly that women play a critical role in the family, not only trying to take care of their health, which they often put off, but they've got to make the decisions for all members of the family. Assuming they're married and have, a husband, let alone perhaps kids. And the reality is they have to figure out the costs, and they are making the decisions regarding, healthcare decisions for the household, which means a burden of overcoming, various challenges and the complexity of the system, trying to figure out, can we afford that cost for that therapy? What does it mean? Do I have to do a balancing act? What steps do I have to go through? Do I have to do extra visits? I guess I'm getting ahead of myself, but the reality of the way in which a PBM can work can lead to extra work for a woman in trying to get her own care, which is if you have to, can you get the therapy you wanted? Can you afford it? Let alone for a loved one, which takes time and effort. This is it's an incredible frustration with our healthcare system that it has these ways in which you are unaware of how you are being impacted by the very system that you have to rely on. And I speak not just for women on that. I think we speak also for men, but women are often the ones trying to ensure that care is being received by everyone.
I'm married and I have a mom, and I know that when I was even a young man in my teenage years, my mom, she was the organizer and she was the captain of the household, so to speak, on health visits, healthcare access, on medicines, and even my mom's the one who paid the doctor bills. She's the one, when I got stitches, was the one who dealt with the hospital and paying that bill and that sort of thing. So, Mike, before we get into your special business and how AffirmedRx is different than other PBMs, there's news today, BioNews today reports that in the Republican reconciliation bill, it was advanced just recently. For us, it was yesterday, they advanced this in the House Budget Committee, and we're told that they're going to be key health priorities, one of which is PBM reform. What they want to do, what I'm hearing, again, things can change. They're talking about measures to end Medicaid spread pricing, delinking PBM compensation from Part D prices, and adding transparency to PBM operations. We can talk about spread pricing and rebates and these sorts of things. But first, let's talk about transparency and the need for transparency in drug prices in the relationship PBMs. PBMs are the pharmacy benefit managers. They are the negotiators for the drug prices, bringing drug prices down. But very often they just pocket that savings for themselves. But talk a little bit about PBMs, talk a little about transparency. And if you want to talk about delinking and spread pricing, go ahead.
No,
I'm
it's
technical.
they're all related, right? They're all related. So, yeah, I mean, the way you set that up is absolutely correct, right? So when a lot of people get their insurance, I mean, you're bringing up Medicare, Medicaid, things like that, right? Which is another pathway to care. A lot of other individuals get their health insurance or their health care through their employer. In both cases, the PBMs sort of operating the same way, which is they're negotiating for the prices of the drugs, but they're also sort of operating to facilitate the distribution, the clinical oversight. They play a very necessary role in the total pharmaceutical landscape, right? But because there are so many moving parts, so many touch points, right? So you've got the drug manufacturer who's making the drug. The PBM is then sort of negotiating the price of those drugs. Then they're going back to the plan sponsor, which is either the government or it's an employer. And they're then having a transaction with what is the plan sponsor going to pay for that same drug. And then you have sort of clinical oversight to make sure, is it the right drug? Is that the best drug that should be done? And then they're distributing it to the pharmacy to make sure that the patient can then go and pick up the drug from the pharmacy. And at each point, there is an opportunity for a PBM to make money. And the traditional PBM model, they are. So one of the big things that they do when we talk about spread pricing is they negotiate the price of the drug down from the manufacturer. Then they turn around and they can charge the plan sponsor anything they want. And there's no reason for them to explain why they're charging what they're charging. So they can pay $5 for a drug, turn around and charge $100 for the drug. And they'll say, hey, we negotiated this $100 price tag for the drug for you. And maybe they say, and we got a rebate for you. And it's $50. And that looks great to the plan sponsor because they're like, oh, that's great. I'm getting a $50 rebate on a $100 drug when the drug actually costs $5. And
Wow.
the PBM itself gets to then pocket that difference, right? So the plan sponsor feels like they're winning because they're getting this big rebate, but they're really paying more than the drug actually costs. And we've really seen a lot of this come to light with new models like Cuban's Cost Plus Drugs
Yes.
entering the foray, right? Because people are now getting to see what the manufacturing cost is plus 15%, right? So that's a pretty healthy margin. And Cuban's open to saying that. He's like, look, doesn't everybody wish they can get 15% on what they're selling? So he takes it at wholesale cost, adds 15%, and that's it. So you can really easily figure out what the actual cost of the drug would be. And that's where we're seeing when we get eyes on some of the traditional PBMs prices, these exorbitant, we're seeing 6,000% markups on certain drugs.
Let me do this because I know Martha has a hard out today. We have her for precious little time. Martha, I hope you come back. I hope that Healthy Women is a constant theme. Your portfolio. Tell us a little bit about Healthy Women. Tell us a little bit about your engagement in the healthcare discussion, and then just for you, some kind of closing thoughts on or thoughts on the PBM reform, specifically what's being put forward in the reconciliation bill. Do you have high hopes that it might pass?
Thank you. I work for Healthy Women, which is a national nonprofit organization that is dedicated to educating women about their bodies and about health issues and diseases and illnesses in order that they can have better informed decisions with their healthcare providers for themselves and also for their families, but particularly women and women in the middle, we call the midlife, where we often start particularly seeing illnesses and diseases creeping up on us and often don't have the time to deal with them. And we do this through various online tools, which we are well known for in terms of our content and our educational materials, and we also are engaged in policy. I have particular lanes that we focus in on access and affordability and safety. And so obviously the PBM reform plays right into the issues of access and affordability because that's directly impacted by the decisions that are being made by the PBM. And it actually goes into safety issues as well. And safety actually is a women's health issue massively because, of course, we've often been fighting over the last number of decades to ensure that the medical care that we are receiving is actually the right care for us and at the right therapy and at the right dosing and at the right everything.
Yes.
And that has been a continuing challenge going forward. But I want to say that going back to PBMs is that they also instill, like, well, you've been talking about not knowing about the pricing issues and the rebates and all of that, which patients are often just like it's a barrage of, of information that they're not even understanding how the system's working. But what's more frustrating, probably for women more than anything, is when we have to go through what's called step therapy or prior authorization, when you know that you need the drug that the doctor just told you that you need, and the other ones don't work. And then there's this time lag when a lot of bad things can happen when you don't get an opportunity to take the therapy that you need. And actually, to even simplify that, it actually occurs to us for birth control as well, where there's certain ones work better than others. Same with any therapy, certain things work better for some
Sure.
people. And then
Medicine
you
is
get denied.
personalized. We've learned this, right? Science tells us that any medicine for you can impact someone else differently because that's the nature of biology and science and that sort of thing. Are you hopeful for PBM reform?
I am. I mean, we have been engaged on this. We've been supportive of collective efforts here in Washington trying to get the bill over the threshold, and we will continue to push. And I can only hope. I truly thought it would happen at the end of 2024, and maybe now's the time. We will
Yes.
be in this state, in this on this issue and present in efforts to try and get it over the finish line.
Okay, well, we're going to continue the conversation, but I want to thank you for your time. I know that time is precious, and thank you. I hope you join us again on many of the issues. Again, this Capital Conversations series in DC, I think, is a wonderful way to kind of make the complex conversational. Healthy Women is doing that on health access, and thank you so much. And we'll talk to you again real soon.
You're welcome. Thank you.
Mike, I don't know about you, but I very much appreciate the vantage point, the perspective of patient organizations.
Absolutely.
Whether they represent a certain demographic or in this case, women's health, there's an important voice here because medicine, science, public policy is not a one size fits all. And one thing that Martha did say, and I want you to comment on it before we get back to the kind of the business of PBMs and reform. Is that she said something? So I'm going to paraphrase what she said, but the right medicine at the right time, to the right patient, at the right cost. PBMs, the traditional model, not so much your operation, because I know yours is a little different. You can tell us how, but how do PBMs kind of interfere with the right medicine, right patient, right time, at the right cost?
Yeah, so there's a lot of different ways that can happen, and I'll say that some of the examples that Martha gave I think are areas where there's an interface between the plan sponsor and the PBM itself, right? So step therapy and things like that can sometimes be a part of plan design, and so that can get a little bit complicated. However, the common problem that we see, and this is related to the delinking portion of the bill, where we're delinking rebates from specific medications and things like that. Like, so what you can see is
the rebates are the negotiated discounts, so to speak.
Yeah, exactly.
Okay,
exactly. And oftentimes, right, the rebates are like this portion of the the drug spend that is seen by the plan sponsor as savings or money that's coming back to them, but it's also a place where traditional PBMs will get additional revenue, right? So for every rebate they get, they will get a percentage of that. And so what we sometimes see is they'll be driving traffic, right? Driving decisions towards specific high rebate drugs, regardless of efficacy, in order to get those percentages of the rebates, right? So that they can get that. Or they'll be designing the formulary with those high rebate drugs as a priority so that people are going to those first so that they can get that revenue out of there. And so that's not good medicine, right? That's not choosing a drug based on how effectively it's going to treat a condition. That's a financially driven decision that's often not easily seen or easily discovered. So it gets kind of hidden in the background. And again, that's right where a lot of this transparency legislation is trying to get to, and where this delinking is if we can detach rebates from formulary decisions or compensation rebate, like where the rebates get sort of tangled into the revenue cycle, like that's really important, because we want, rebates can be effective. I think there's a future where they don't exist, but they can be helpful in making, and when used as the way they're supposed to be originally designed to save money for the patient, if they are used correctly, they can be a cost savings measure, but they're not being used effectively, and they're being used to sort of, create these convolutions and these problems.
Let me ask you this, and maybe this is a little bit off topic, but small businesses or even large businesses, how do the PBMs help or hurt a small business owner who's providing insurance? Offer some insight there. Like, for instance, your clients, small businesses. Yeah. I mean, what is AffirmedRx? Who are you serving? Are you serving patients, obviously, because of your negotiation and with the drug prices? But do you serve small businesses? Do you serve nonprofits, a big business? How do the PBMs impact kind of the business world?
Yeah, so it's not necessarily a how. I guess it's more of a how much, and it's to what extent.
It's always Mike. It's always how much,
right? Because so we're going to have to sort of define two separate types of business, and these exist within all market positions. So it's not necessarily like nonprofit versus, for profit, or governmental versus commercial. What we usually group things into are what's called fully insured or self-insured. Fully insured is usually your smaller companies, and they're going to be purchasing healthcare from, a standard insurer that gives them like a full product. They're running all the claims. They're doing the underwriting. It's like a standard full model. And they have the least power to negotiate anything, right? So, because if they're buying into, say you buy a small group plan from Cigna, right? You're going to be buying into their entire system. So, and that's where you've seen the sort of the build out and the vertical integration. So like if you have a plan through Cigna, you're going to have Express Scripts. You're going to have, right, like all of this is going to be contained within that. And so you're kind of stuck to their model, and they're going to take every inch of that revenue that plan is creating.
The PBMs like to make money. Is that what you're saying? Although, I mean, again, we all like to make money, but there's there's excess as well.
Exactly, and also in this case, right, like this stands in contrast to a self-insured company, right, which is underwriting its own plans. And in that case, the organization like Cigna or whatever is a third-party administrator, and they're just running the claims for you. And sometimes they'll do that, and they want you to work with their PBM. And in most cases, they want you to work with their PBM because they say it'll save you money. But really, that's just another way for them to get that additional revenue. And it's really in that space, in the self-insured space, which is typically over like 1,000 lives plus, right?
Sure.
Like
Yep.
represented. That's not a hard rule, but that's pretty close to what you'll
But
see in the actual
that's
market.
still a big. That's still a lot of people.
It is,
I
yeah,
mean,
and so
getting
like
access
when
to
you see
healthcare.
that and above, right? Those are the employers that really have the most power, and those are the ones that have the most to lose and are spending the most on their health insurance and in their pharmacy spend, right? Because it's actually hitting their books, right? They're the ones paying out the claims. So
Sure.
if it's mismanaged, those costs can be astronomical. And so they're looking for better partners, and they're looking for people that are actually trying to get their employees healthy so that their dollars are in place. And that's where we've seen, right, over the last, in 2021, the Consolidated Appropriations Act of 2021 was passed, which expanded the fiduciary requirements of plan sponsors to include all of their healthcare spend, right? So they are, and there's a lot of provisions in there, but the fast read of it, right, is if they're mismanaging their healthcare dollars, they are legally liable. And that's where we've seen some lawsuits hit the market recently in the PBM space for people being accused of spending exorbitant amounts of money for specific drugs that are on formulary because they weren't paying attention to what the traditional PBMs were doing.
Now, I want to make sure that we talk a little bit about AffirmedRx, and then I'm very mindful of the time and your time. But can you tell us a little bit about how AffirmedRx operates and how it's different than the traditional PBM?
Yeah, so what we've done is, one, we were launched as a public benefit corporation. So our founder, Greg Baker, wanted to make sure that in the healthcare market, it's not necessarily bad to make a profit, but it is if you're doing it at the expense of the patient. So he wanted to launch it as a public benefit corporation where we put patients over profit, where our true focus is on delivering the best type of care at the lowest possible cost. And so that's how we were structured. And then we're built to be 100% transparent. And I mean that in every way, right? There are no hidden fees. There are no hidden revenue. We make revenue from a single point, which is an admin fee that's all inclusive. And so there's no complicated contracting where we're hiding little additional services or savings models or things that we're doing. We don't take any money off of any rebates. So 100% pass through for all rebate dollars. So everything is going to where it's supposed to be. And we're 100% transparent about it. So you know everything that's in there and as it's going through. And then we build our formulary all towards this net cost savings. Since we're not taking any of the rebates, since we're not taking any of those additional fees, it's in our best interest to charge you for the least amount for each drug. And we're looking at clinical efficacy. So when we're building out our formulary, we're building it out based on what are we seeing the best outcomes for? And then we're looking, okay, is there a generic? Is there a biosimilar? Is there a cost savings way to provide the same level of care? And then we build that out. And then through that, we're able to guarantee a 10% net cost savings, dollar for dollar for against like the previous PBM. It's amazing how much money you can save just by doing the right thing.
Yeah, it's interesting. It seems to me that what you just outlined in 90 seconds, best outcomes, patient savings, 100% transparency. If that were the law, if this is the reform we might see to make the big PBMs, and there's three big ones that have 80% of the market or 80% of the drug claims. Imagine if they played by similar rules. Last question: do you see an avenue? Are you hopeful that we'll see some reform?
Yeah, I do. I think we are. I mean, I think what we see is bipartisan support of all of this.
Yes.
And that's incredibly important. And then the other thing that I think is really important is that we're seeing, as we're traveling around and interacting with people, we're seeing people at the state level also looking to do similar things within their states, writing similar bills. And so when you have that sort of top to bottom momentum towards change, I think it's absolutely going to happen. And what I think this does, I don't think it's a panacea, right? To borrow our pharmaceutical language here, right? It's not going to fix everything overnight because whenever this legislation hits, the traditional PBMs have an army of lawmakers, or not lawmakers, sorry, but lawyers who are going to look at the new law and they're going to figure out a way to keep making money, right? They're never going to give up an inch of their profits. But what it does is it carves out a market gap for new PBMs, next gen PBMs like us.
If I had a bell, I'd be ringing the bell right now if I had a bell on my desk here.
Right. And that gives us the opportunity to win the business, to show people how it should be. And I think that's the important piece of this legislation. So we're really excited about what's going on. We're really keeping our eye on it. We've got, our CEO Greg has testified before the FTC that we're in the fray, because we think what we're doing should be table stakes. We shouldn't be out there talking about that shouldn't be our differentiator, right? And we think that everything else we do is great too. But we think that that should be the playing field, right?
Yes.
So we're excited to see that happen.
Mike, I love it. Also, I have some notes that I keep on the side here. And one thing I had circled, and I never said it in the 30 minutes we've been together, and that is there's lots of bipartisan agreement. And that's one thing that I find very encouraging, being involved in politics and policy and healthcare for 20 plus years. I do see a lot of bipartisan support. I see a lot of progressive, conservative, libertarian kind of support around this and reform. Again, the right medicine at the right time, at the right cost, to the right patient. I think that's something even the most ideological opponents could agree upon. So I'm so happy that I've learned more about AffirmedRx. We met at the HealthyWomen's panel on PBMs, and I hope that you'd come back and talk more about this. I don't think 30 minutes is enough, and I like to swim around your mind for a while. My mother would say that Mike has a head for knowing. And I think that's how I would describe you. You have a head for knowing. I appreciate your wisdom today. And Martha, thank you so much. This has been albeit incomplete because we don't know what the next steps are. But I want to thank the audience. I'm Jerry Rogers, your host. And this was another edition of The Business of America.
This has been the Federal Newswire's Business of America podcast, hosted by Jerry Rogers. Check out the Federal Newswire's family of websites, as well as their social media stream